Role of anesthetist in obstetric unit. So in obstetric unit, anesthetist plays a crucial role in providing safe and effective analgesia and anesthesia for labor and delivery, including cesarean section. They help in the management of obstetric emergencies like sepsis, postpartum hemorrhage, or hypertensive crisis. They also help in managing critically ill obstetric patient, serving as a peri-delivery intensivist or peripartum physician. Pain management and anesthesia. Anesthetist alleviates the stress of childbirth without any harmful effect by providing safe and effective analgesia. Labor analgesia. The anesthetist provide pain relief during labor, often using technique like epidural, patient control analgesia. They administer anesthesia for cesarean section, ensuring the mother's safety. They are also involved in anesthesia for other obstetric procedures like exit or fetal surgeries, acute appendicitis, etc. For postpartum pain management, anesthetist plays an effective role in managing pain by using tab block, patient control analgesia, NSIDs, etc. Management of high-risk pregnancies. The anesthetist plays a key role in the management of high-risk pregnancy and must be a member of the multidisciplinary team that is required to care for the critically ill obstetric patients. Pre-op assessment of women with pre-existing medical disease like diabetes, hypertension, anemia, cardiovascular disease. Anesthetists must be adapted to empower the physiological changes in pregnancy. They play early assessment and optimization of the high-risk pregnancy during antenatal period and providing high level of care in the postpartum period that helps to reduce the mortality. Managing the anesthetist experience in managing critical care patients as they are expertise in advanced life support and resuscitation, hence help in managing maternal sepsis, hemorrhage, hypertensive crisis, and other obstetric emergencies. Education and training. Obstetric anesthetists should undertake education of the medical and midwife staffs in early recognition, monitoring, and treatment of the sick mother, to conduct resuscitation training and running skill drills for emergency simulations. They also help in the risk management and audit of maternal mortality on the labor ward. Okay, sir. Yes, sir.
Right. It was a very crisp and short presentation, but I think something more needs to be added to that.
Okay, sir.
Just this is a question which was asked about 5 years ago in one of the theory exams.
Okay, sir.
That's the reason why this question has been asked. So the role of anesthetist in the obstetric unit. First thing, there are the care of the patient. Now we have now super specialty training in cardiac anesthesia, neuro anesthesia, pediatric anesthesia. Similarly, obstetric anesthesia is also trying to emerge as a super specialty training because of the complicated high-risk obstetric patients nowadays we encounter, especially when ladies have started working in the IT and other departments. Their marriageable age itself is going up. Earlier, they used to get married between 20 and 24. Oh, the marriageable age of ladies is going up to 30, 35. And the first pregnancy occurs quite late in their life. And that invariably leads to high-risk pregnancy with more complications. So because of that, the need for specialist obstetric anesthetists is increasing. And their role has become very important in the clinics and classes of the delivery suite as well as obstetric care and high dependency and intensive care units with where the critically ill obstetric participants are there. So their services are needed both for the operative anesthesia for cesarean and other surgeries, as well as for providing pain relief. So nowadays, many mothers are aware of the labor analgesia and they ask for it. Earlier, it used to be the physicians themselves used to discourage patients, saying that, "Oh, you want that? It will invariably lead up to instrumentation and delivery of the baby. So why not you bear it for a few hours and get rid of it?" So they used to discourage like that. But nowadays, many physicians are encouraging mothers to uh, have obstetric pain relief done by the qualified anesthesiologist. So that also requires the expertise of an anesthetist who's trained in that, so that the incidence of dural puncture is very much reduced, and they are able to do this particular technique very efficiently and provide the mother with good labor pain relief. So now all these areas they require as a part of obstetric team, and they are able to manage any life-threatening complications because of their skill in the emergency the management of all trauma or other critically ill patients. That training also helps the anesthetist in managing these patients who are invariably having a eclampsia or a hemorrhage. Those patients are resuscitated better by a anesthetist rather than by a like a physician or a gynecologist. And sometimes they may help in the resuscitation of the newborn also. Supposing there's a delay in the arrival of your neonatologist in the during operative delivery, and baby is born with a Apgar score of say the 3 or 4, then the anesthetist will be able to immediately revive till the neonatologist arrives in the scene. So for tough patients, this may also be the skill of the anesthetist which may save the baby. So their service is required to provide anesthesia for operative delivery, administration and audit of regional analgesia, that is labor analgesia, and managing severe illness in obstetric patients like the hemorrhage or eclampsia, and transfer a sick patient from one unit to another. That also may be the job of a qualified anesthetist. And they can train the junior anesthetists who are coming for obstetric training. That may be the service of the obstetric anesthetist, and they may educate the non-trainee or paramedical people or people involved in obstetric anesthesia services. They may be able to train them, the nurses and other people, how to manage and educate the midwives and their training and service. So these are all the things that an qualified anesthetist can do, and they can also educate the mothers right from the first term of pregnancy, right, first trimester. They can teach them about the non-pharmacological and non-interventional methods of labor pain relief like yoga, breathing exercises, and all those things. Nowadays, classes are conducted for pregnant mothers right from the first trimester to cope up with the labor pain. So there also the obstetric anesthetists will have a major role to play, and they can use updating the obstetricians about the scope and limitation of obstetric anesthesia, and the participation if requested in pediatric service in resuscitation of the newborn, even though the primary responsibility is with the mother only. So mostly the mother's life is in the hands of the obstetric anesthetist. And how to staff the obstetric anesthesia units? Who are all the persons who should man these services? There should be a good senior consultant anesthetist who has the minimum of 10 years experience in obstetric anesthesia. He should be heading the unit, and there should be the adequate number of duty anesthetists, because obstetric anesthesia has no time frame like other people. Anytime you can land up with a need for an emergency category 1 cesarean. So adequate anesthetist should be available all the time, and there should be a resuscitation team available immediately, because even during normal labor you do not know which patient may suddenly go for postpartum hemorrhage. because of uterine atony or rupture or some other injury. So the resuscitation team should always be ready. So this should be the staffing pattern. The senior consultant with adequate number of duty anesthetists to give 24/7 all the through a year with an adequate number to come in rotation, and the resuscitation team. Now, if the obstetric unit is going to provide labor analgesia in the form of regional anesthesia services like epidural, then it should be a 24-hour demand epidural analgesia service. And it should ensure the presence of a qualified anesthetist in the hospital. That is, you can institute the epidural and then give instructions to the nurse and ask them to top up and give the continuation of the labor analgesia. But any complication, the qualified anesthetist should be available within the premises of the hospital so that they can immediately come and attend on the mother. Then there should be acceptable anesthesia response time. What is this particular means? Because in maternal emergency time, a trained team of who are trained in cardiopulmonary resuscitation of a pregnant woman. Because CPR in a normal patient is slightly different from CPR in a pregnant woman. Can you tell me what is the difference, Muthupriya, in CPR of a pregnant woman?
CPR should be started within within 5 minutes of the perimortality.
No, that is perimortem cesarean section. I'm asking about CPR difference in a pregnant woman. Supposing a full pregnant woman before delivery has suddenly developed a cardiac arrest. What is the important difference between a normal patient being given a CPR and a patient who is
the position of the
uterine compression? How you remove that and try to do that? Very important. If it is a single person, you must do the tilt the patient to the left lateral and do the CPR compressions. Whereas if it is a 2% resuscitation, you must ask another person to shift the gravid uterus out of the IVC and shift it towards the left so that venous return will happen. Okay, that is a very important difference between a pregnant woman CPR and a normal patient CPR. So this must be available within the obstetric unit at all times. And in cases of complications like total spinal, when you give an epidural block and inadvertently it has become a total spinal, or in cases of massive blood loss or pulmonary embolism, then you require a dedicated team which should immediately be able to come. This is the very urgent response time of the anesthesia team that should happen in emergencies, number one. And the duty obstetric anesthetist should not undertake duties outside the obstetric unit. He cannot be deputed to some other trauma unit or general surgery emergencies, because you do not know what time there may be an emergency like this happening in the obstetric unit. So those anesthetists who are attached to the obstetric unit should be looking after only obstetric duty, and they should not be deputed or diverted to other services. That is very important thing in the role of the anesthetist in the obstetric. Then coming to the fetal emergencies, fetal distress may happen, which may require operative delivery, and which need a very short response time. So maximum the time by which the operative delivery should start once you address the fetal distress is maximum 30 minutes. And because conditions like prolapsed cord or the fetal bradycardia, it is better that the mother is operated at the earliest so that we can salvage the baby. So this is the second response time. Within 30 minutes of information of fetal emergency, you should be able to attend to the patient. Then the third response time is regional analgesia for labor. It is when the mother is opting for labor epidural, then again there should be the anesthetist should be able to institute the labor epidural if indicated, that is right at the end of first stage or early second stage. You should institute it within 30 minutes, and the maximum time allowed is 60 minutes. Within this time, an efficient obstetric unit should be able to institute the regional anesthesia for the mother. Now, coming to the question of giving anesthesia for cesarean delivery, anesthetist should have a thorough pre-op evaluation, and with interdisciplinary guideline, grouping and cross-matching should be done, and oral intake and use of agents to reduce volume and acidity of gastric content should be thought of, and patient should be visited and assessed by anesthetist prior to arrival, unless it is a category 1 cesarean section where there is no time for you to go and assess. It should be a routine in all cases. And an elective cesarean delivery delayed for more than 4 hours, the mother should be given the option of an intravenous infusion to maintain hydration. So this is the elective list. If for some reason the surgery getting delayed, this should be the option given to the mother, and the surgery should be proceeded with as early as possible without further delay. Now coming to the monitoring for operative delivery under regional block, continuous pulse oximetry, NIBP at 1 minute interval, preferably with a printout to know whether there has been any sudden hypotension as a documented evidence, and continuous ECG monitoring are required from beginning to end. Even before starting the spinal, all these monitors should be applied and baseline parameters should be recorded, and it should continue until the end of surgery and then continued in the post-operative period at least for the first 30 minutes. So fetal heart rate should be recorded, especially during initiation of regional block until abdomen skin is prepared in emergency cesarean section. This is another important criteria. And obstetric theatre, recovery, HT, ICU facilities, where it all should be settled is a dedicated operating theatre should be there for the obstetric cases, operative cases in all the obstetric units. And this should be on the same floor or adjacent to the delivery suite, so that in case suddenly there is a delay in the normal delivery and you think of putting the patient for surgery, the theatre should not be in another building. So it should be in the same floor and in adjacent or in continuity with the labor ward or the delivery suite, so that patient can be immediately shifted for surgery. And you should have a spare theatre also. The second facility may be there in the event of emergency. So you should not make a patient with a category 1 cesarean waiting too long. By having only one theatre, you should not say that until that earlier cases finishes, I will have to wait. So there should be one dedicated theatre for emergency all the time. And the operating theatre should be fully equipped with all the standard equipments and
Sir.
yes. This area should be separate from the operating theatre, but also in the close proximity and preferably in the same floor of the building. And the post-operative care of the obstetric patient should be in accordance with the case of any post-operative patient with regard to pain relief, hemodynamic stability, and watching for any bleeding. All these things should continue for the obstetric patient. And continuous clinical observation for a straightforward delivery or a cesarean should be at least minimum 30 minutes post surgery or post delivery. And discharge from the recovery area to postnatal wards in accordance to the regular protocol that should be followed in all the other surgical patients. And the maternity unit with obstetric anesthetic services, high dependency care should be always available. If it is a regular obstetric unit, it should always have a separate ICU like ward. And it should also be adjacent to the delivery suite, especially if you are dealing with a pre-eclamptic patient who is likely to throw a fit all the time. then this high dependency unit should be very close to the operating theater and delivery suite so that they can be immediately taken there and if necessary intubated and ventilated, all those services can be done. And facilities to transfer the patient to intensive care should be available in the same hospital, or it should be at least very close by where you can shift the patient. And a trained anesthetist, obstetric midwifery staff should be required to accompany the patient whenever you need to shift them from one floor to other floor or one unit of the hospital to another area. And assessment of the sick obstetric patient, medical conditions or complications in pregnancy should be assessed by the obstetrician well before delivery so that you can take care of the patient. The guidelines that should be followed are antenatal referral to the anesthetist should be done for all elective cases so that you can have an idea about the airway as well as the spine and other comorbidities that the patient may have. Major hemorrhage management protocols should be always be available in case of either intraoperative or postoperative bleeding. And pre-eclamptic toxemia management protocol should be available that should be followed regularly about the station of magnesium sulfate and monitoring during magnesium therapy, etc. Failed intubation drill to be done periodically. This is very important because nowadays we are routinely giving spinal for all obstetric operative delivery. Rarely you may be required to do GA when there is a contraindication for spinal. So in that situation, the major reason for shifting from GA to spinal was because of the failed intubation and the obstetric death that happened because of failed intubation in the European countries. And this technique of giving GA is becoming slowly forgotten art because of the lack of chances that patients and the anesthetists have. So this intubation drill should be routinely performed so that they don't forget this art of intubating a pregnant mother. And management of regional anesthesia, including regional for labor epidural as well as a routine for surgery, that should also be done in the obstetric unit. And how to manage unintentional dural puncture and post-dural puncture headache is also part of the training that you should have. And severe hypotension management protocol should be thought of in all these patients. And management of total spinal in case if this problem happens, that also should have been trained and taught into all the patients and the anesthetist. And admission and discharge criteria from delivery suite to high dependency unit also should be thought of and trained in these cases. So that these are all the things that you have to include in your answer for the role of anesthesiologist in the obstetric unit. Okay.